Good evening and a warm welcome to everyone for joining us on one of the very enlightening sessions of the Indian Thyroid Society's Thyroid Clinics webinar. So before we begin today's session, let's take a brief moment to watch a video on the Indian Thyroid Society, which highlights our society's mission, the initiatives, and also its impact to create awareness on thyroid health across our nation. So I request the tech team to play the video. So moving forward, the thyroid clinics is currently being conducted under the dynamic leadership of Dr. Pramila Kalra Madam, who is the president-elect, and Dr. Roma Pradhan Madam, who is the EC member. Also, we have Dr. Narendra Kotwal sir, who is the president of ITS, Dr. Arun Menon sir, the secretary, and Dr. Mini ma'am, the treasurer, who's always inspiring and guiding us through this journey. We also have Dr. Chitra Madam and Dr. Vijay Reddy sir as part of the thyroid clinics team. So I now request our President-elect, Dr. Pramila Kalra Madam, to give the opening remarks.
Yeah, thanks, Dr. Ganvi, and I thank everybody for being here today because these clinics we are doing it for past 2 years around now, and they have been a huge success amongst the DM residents. The purpose of these clinics is basically to discuss cases concerning thyroid, whether it is endocrine surgery, endocrinology, or nuclear medicine. So that's the purpose of these clinics, and that's why we try to see that all the faculty from different specialities are a part of it. And many of the faculty have been part of these clinics, and many are now going to be part in future as well. So I hand it back to Dr. Ganvi to take further the proceedings for today.
Yes, ma'am. So a short announcement before we proceed further. So we have our flagship journal, that is the Thyroid Research and Practice. Those who are interested can do so, can submit their research by scanning the QR code displayed on the screen. And also those who are interested to become a reviewer for the Thyroid Research and Practice journal can do so by scanning the QR code, which will help you sign up as a reviewer. So moving ahead with today's program, so our session for today, we will have a case presentation. The presentation will be by Dr. Sriram, who is the senior resident in the Department of Endocrinology at People's College of Medical Sciences, Bhopal. The case discussion will be moderated by the distinguished faculty, Dr. Sushil Gupta sir from Bhopal and Dr. Anish Bail sir from Mysore. We will then have a very insightful presentation by Dr. Divya Dahiya Madam, who will deliver a talk on risk stratification in DTC, followed by quiz by Dr. Parag Agarwal at 8:50 p.m. So moving on, I'd like to invite the moderators for the case discussion. So I think, yes, I'll give a brief introduction, sir.
I think the first slide is wrongly written here, Professor R.K. Sharma Award. Okay, doesn't matter.
Yes, sir.
Okay.
So, moderating our case discussion is Dr. Sushil Jindal, sir, ex-professor and head professor emeritus of the Department of Endocrinology, People's College of Medical Sciences and Research Center, Bhopal. Sir has written numerous chapters in the RSSDI textbook of diabetes, has numerous publications in many peer-reviewed journals, and sir has also been the former chairman of RSSDI MP chapter. And sir has been the organizing secretary of ESICON 2013 conducted in Bhopal. And the next moderator for today's session is Dr. Anish Bail sir, who is the consultant endocrinologist at Apollo BGS Hospitals, Mysore. Sir is a well-known figure in the field of endocrinology. So moving forward, I'd like to invite the moderators to give their remarks and start the case discussion.
Thank you, Dr. Ganvi. It's my pleasure, and I must thank Dr. Pramila Kalra for inviting us here along with my student, Dr. Sriram. So we know that many a times in our practice, we find patients in whom we are giving pretty high doses of or unusually high doses of thyroxine, but their TSH is not normalized, and such refractory cases are not uncommon. And there are various reasons for that. common reason being non-compliance from the patient side, but there are some other rare causes also. So we are going to discuss two of such cases. I invite Dr. Shriram to present those cases. Over to Dr. Shriram.
Good evening, sir. I'll be starting my presentation now. I think my presentation is visible now.
Shriram, please to share the slides.
Yes, sir.
Yes, down below there is a green colored share option.
Yes, sir. I think currently it's being shared.
Yeah, make it full screen.
Yes. Good evening. So today I will be presenting two interesting cases of refractory hypothyroidism. So the first case being she was a 17-year-old female who presented to us with complaints of intellectual disability. So she presented with intellectual disability and developmental delay. There was no history of birth trauma, head injury, seizures, or altered sensorium, no history of palpitation, tremors, weight loss or weight gain, constipation, diarrhea, or sweating, no history of hoarseness of voice or facial puffiness, no history of breathlessness, pedal edema, or any other urinary complaints, no history of excessive hair fall, muscle weakness, or dry skin. She had not attained menarche when she presented to us. All her developmental milestones were delayed. Even the mother was the informant, and she recalled that all her developmental milestones were delayed. She was diagnosed to have congenital hypothyroidism, cretinism at third month of her life, and she was on thyroxine on various doses based on weight during her follow-up. As per the mother, technique and compliance was proper. Birth history: she was born out of full-term normal vaginal delivery. Umbilical hernia and jaundice were present at birth. Jaundice was present at birth. It lasted for about 2 weeks, for which she received phototherapy. Poor feeding was present. No history of any drug intake by mother. There was no history of CNS infection. Index child is born of the three children, second born of three children from a non-consanguineous marriage. Other two children were normal. Family history wise, father was hypothyroid and was on thyroxine. Examination: her pulse rate was 98 beats per minute regular, BP was normal, saturation was normal, weight was 33.2 kg, which falls between 3rd to 10th centile. Height was 147.5 centimeter, which again falls between 3rd to 10th centile. Height age corresponding was 12 years. BMI was 15.26 kg per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. On general examination, there was goiter, voice and hearing was normal, no cleft palate or other dysmorphic features. Intellectual disability was present in the form of there was a language problem, social skills. She had poor social skills, and she was not going to school because of intellectual disability. Reflexes were normal, no ataxia. Cranial nerves, motor system sensations were normal. TANRA staging was B2, P2, and her other system examination were normal. Coming to her blood reports, there are some previous reports also. She presented to us around in the month of August, in the month of June or August in 2024. There are some 2-3 previous reports also I have mentioned here. Based on this, we can see that her TSH was never controlled on her thyroxine with the proper weight-based treatment, weight-based dose, and proper compliance and technique. Free T4 was always free T4 was normal. However, TSH was never controlled till here. This was after our intervention, the last report. Till here, her TSH was never under control. And T4 was also low. Total T4 was low normal range, and T3 was also again low normal range. Bone age was 15 years, and her anti-TP was positive. So explaining in detail, patient was taking a dose of 62.5 kg, which is appropriate for her weight, actually more than the appropriate dose. During that time, her TSH was 28, free T4 was 1.05, and this was before coming to us, she was advised to take 75 mcg of thyroxine. And here in June 2024, again her TSH was 13, free T4 was 1.47. Again, she was asked to continue the same dose. In the month of August 2024, she presented to us. Again, TSH was 27, free T4 was 1.22. Here we suspected again because of poor compliance, she has mental retardation she had, and we thought she was neglected at home or all those problems. So we also advised her to continue the same dose because it was more than her weight-based dose. And when she came to follow up during next, that was September 2024, again TSH was raised, free T4 was 1.14, and that time we thought that there would be some compliance problem, so we advised the patient to take a supervised dose. That is, we advised the mother give her 75 mcg of thyroxine weekly supervised dose, 5 tablets weekly once. And again, in the month of October, she presented to us. Again, it was not under control because she was not taking the supervised dose. So we again advised to take supervised dose. And yeah, in the December also, she presented us again. TSH was very high, 100, and free T4 was 1.3. So we increased the dose to 6 tablets per week. Even though it was more than the physiological advised dose, we increased the dose. And in January, she again we continued the same dose, thinking that there was something. And again, we thought mother would be missing something, so we labeled the thyroxine tablet new box and counted the tablets also during follow. So in spite of all these things, till March 2025, also her TSH was not under control. In July, in month of June, when she presented to us, we thought of this thing and we intervened her with adding T3 leothyronine 20 microgram. With that, she responded with in the next follow-up, that was August 2025. Her TSH came to normal, and T4 normal, and T3 also, which was always low, had come to actually 180, 190 is the cutoff, and 290, it was on the higher side. So we asked to continue the dose. This is about the first patient. Coming to the second patient, here is a 23-year-old male patient who came to us with complaints of intellectual disability again and poor scholastic performance. He also stopped going to school due to poor scholastic performance. There was no history of any other birth trauma, head injury, seizures, or altered sensorium. There was no other history suggestive of hypo or hyperthyroidism in that patient too. All his developmental milestones were also delayed. He was detected to have congenital hypothyroidism and labeled as cretinism at 6th month of life and was on thyroxine. Again, as per the informant that was father, technique and compliance was proper. Birth history, full-term normal vaginal delivery, no umbilical hernia or jaundice at birth, poor feeding was present, no history of any drug intake by the mother, no history of CNS infection. Index child is second born of two children from a non-consanguineous marriage. Other child was normal and no other significant family history. On his examination, again, everything was pulse rate, BP, everything was normal. Weight was 50 kg, height was 163, BMI of 18.82, no pallor, ectodermal cyanosis, clubbing, lymphadenopathy, or edema. Goiter was present. Voice and hearing was normal. No cleft palate or any other dysphonic features. Again, he had his language and social skills were fairly okay, but he had poor scholastic performance, so he had quit this school. Reflexes were normal, no ataxia. Cranial nerves, motor system, and sensation were normal. No other system examination were normal. Again, Tanner was P3. So coming to his investigation, again, these are to his previous reports, and he presented to us around April 2024. Again, his TSH was always high in spite of proper technique as per history. So we performed a LT4 absorption test in him. Again, it was negative. There was no malabsorption in him. So we asked. These are his reports, and I'll be explaining it in detail. So these are his reports. Here again, before he presented to us, there was problems in the patient side, that patient used to take in wrong technique or patient used to stop medications. So we asked the patient to continue the same dose, and here we asked the patient to continue the same dose. And in spite of that, his TSH was high, so we did a LT4 absorption test, which was negative. In spite of that, his TSH was always high. It ranged from actually up till 100. It has gone from 20 to 100. It has ranged. And again, for him also, we advised supervised weekly dose of 100 mcg
Hello, hi Divya
initially.
ma'am. This is Muntaha calling from V2 Technologies.
बताइए.
Dr. Divya, can you please
Hello.
mute yourself? Dr. Divya, please mute yourself. You're unmuted.
Hello.
You are audible. Please mute yourself. Yeah.
Shriram, go ahead.
Yes. So we had advised again supervised weekly dose of 100 microgram to be taken a supervised dose weekly. Again, with that, it was not under control. So we escalated the dose to 150 mcg. In spite of that, his TSH was not always under control. So we intervened here with adding 20 micrograms of leothyronine. With that, his TSH is coming down, and latest TSH was 5.02. And his T3 was under normal range, T4 was also under normal range. So with this, we came to a diagnosis of congenital cretinism with the proved refractory hypothyroidism, which responded to leothyronine.
Shriram, what from the history, what do you conclude that what are the various possibilities in this patient and why patients develop refractory hypothyroidism? Can you elaborate on that?
Yes, sir. In our patient, he had the diagnosis of congenital hypothyroidism with cretinism was there because there was neurological deficit that is intellectual disability was present, and refractory hypothyroidism is defined as when the dose requirement of more than 1.9 microgram per kg body weight, in spite of taking that much dose. Requirement is more than that, and TSH is still not under control, then we tell that there is refractory hypothyroidism. And most common causes would be again compliance would be the first cause, poor compliance or improper technique, and drugs interfering, taking the tablets along with the interfering drugs like calcium, iron. That could be the commonest. These are the three most commonest causes. However, next coming to the other rarer causes would be LT4 malabsorption. Even we had done like LT4 absorption test in one of the patients here, which came out to be negative. So then
Shriram,
still rarer cause.
how do you do the malabsorption test? Can you tell the audience?
Yes, LT4 malabsorption is done. There are first patient is asked to come to the hospital with the empty stomach, and then we get a baseline free T4 level. And once the free T4 level we give him the weekly dose that is calculated according to the normal body weight dose, that is 1.6 microgram per kg body weight into 7. That is the weekly dose we give him a stat, and then we ask him to be NBM only till the next repeat free T4 is done. Repeat free T4 is done after 3 to 4 hours, and then we take interpretation, that is if there is a rise in free T4 by more than 50%, or the absolute value of free T4 increases by more than 0.4 nanogram per deciliter, then we say that there is no malabsorption. If it is less than that, then we say that there is some amount of malabsorption. Again, the causes could be lack of gastric acid, then celiac disease, celiac sprue would be the commonest causes.
H.
And the
pylori?
otherwise we label as pseudo malabsorption, that is improper technique or something.
Okay, go ahead.
So with these things, we kept our differential diagnosis as compliance and technique. Again, we checked to the maximum possible way and it was almost not there. Technique and compliance was good only. And then the heterophile antibody interference in the TSH measurement, that could be the cause, we thought. And we repeated in the various labs. We sent it to after precipitation and all. We done from the 2-3 different labs also. We got the TFT done. Again, it was showing the same thing. Then we got a LT4 absorption test. So then again, it came to be normal. So now coming to the rarer causes, we think of here DA2 polymorphism more likely, and the other which we thought of, which is not here, but we thought of was RTH beta, that is resistance thyroid hormone beta. So our current working diagnosis would be because it responded to T3 as well. So our clinical diagnosis here would be D8 polymorphism would be the cause for this.
Okay. Can you show us some review for these two possibilities?
Yes, sir. So coming just briefly,
Quickly.
as I mentioned, yeah, refractory hypothyroidism is persistent TSH despite taking the dose of more than 1.9 microgram. Common causes will be poor adherence or proper technique, malabsorption, as I mentioned earlier, ectopic gastritis, pernicious anemia, celiac disease, inflammatory bowel disease, short bowel syndrome, post-bariatric surgery. There will be 20% increase requirement in the LT4. So that would be the causes. Then the interferon drugs, as I mentioned earlier. Even we had done a study in our institution, which got published a few months back in Thyroid Research Journal. Where we studied the levels of malabsorption. We found that 12%, that is 6 out of 50 cases in our had malabsorption, and rest were pseudo malabsorption, and 88%. The other would be increased requirement like pregnancy, obesity, nephrotic syndrome, liver diseases. Then the other coming to the rare causes, that is DA2 polymorphism, TSH resistance. So we follow the diagnostic flow chart. That is, first we check for the adherence, then we check for the technique compliance, then we look for the malabsorption and increased requirement, and then we go for rare causes like DA2 polymorphism. So this is the brief slide which shows how the TSH is absorbed from the blood. T3 is this in the CNS. T3 enters the astrocyte through MCT8 receptor, and there again through from the astrocyte into the nucleus of the neuron by again MCT8, and acts by TR beta receptor, and we get the response. T4 also enters the astrocyte through OATP1C1 transporter, and there again D2, that is DAO2 or type 2 deadenase, converts T4 to T3, and that T3 is again transported by MCT8 and enters and acts. So, how to differentiate between the commonest causes of raised TSH with with the normal T3 T4? So this would be the three differential diagnosis. So overview would be RTH beta. It is due to TRH beta mutations, DA2 polymorphism because of reduced conversion of T4 to T3. MC88, that is Allan-Herdon-Deadly syndrome, that is due to defective transport. Hormone profile would be usually in isolated these cases. Free T4 will be free T3, free T4 will be increased. TSH will be normal or raised, mild. DA2 polymorphism usually normal TFT if it is alone, and low free T3 to free T4 ratio post therapy. MCT8, T3 will be increased, T4 decreased, normal or mild increased TSH. Clinical features, RTH beta will have goiter and peripheral thyrotoxicosis features like tachycardia and ADHD like symptoms. DA2 polymorphism, patient will be having persistent symptoms despite even if the TSH is normal, also they will be having persistent symptoms. MCT8 mutations will have neurodevelopmental delay. And genetics wise, it is autosomal dominant. This is polymorphism, threonine alanine polymorphism. MCT8 is X-linked. So this is the differentiating figures here where we see here goiter is usually present with RTH beta, and the other two there will be no goiter usually. And genetics, as I mentioned. Diagnostic clue would be high free for the inappropriate TSH. DO2 symptoms persist despite normalization of the TSH. And MCT8, there will be T3 increased, T4 decreased with neurodevelopmental delay. Management would be RTH beta by peripheral to act on the peripheral thyrotoxicosis features, beta blockers, and triac. And even a supraphysiological dose of T3 can be tried. DAO2, again, LT4 proper dosage should be added. Then we should add, we can consider LT3, which we have done in our patient. And MCT8 patient, MCT8, we can, there are only supportive care with the DITPA is being tried. And coming to our case, which was autoimmune hypothyroidism, because anti-TP was positive in both the patients. Along with that, we have DI2 polymorphism. So autoimmune hypothyroidism typically responds well to LT4 therapy. In DI2 polymorphism may alter T4 to T3 conversion. So persistent symptoms, despite the reports, will be there. And clinical features like DO2 polymorphism will be having residual fatigue, cognitive issues despite normalization of the TSH. And here in this we require only LT4, and in the DA2 polymorphism, FT3 may remain low or normal. FT4 will be slightly on the higher side, and normal TSH. So, which treatment wise, it responds well to the LT4 therapy, autoimmune hypothyroidism. But in DA2 polymorphism, we need to add T3, liothyronine, which we have seen in our patient too, where it reduced significantly, dropped significantly to the normal range of around 4 to 5. Still not fully normalized, but in the it has come down significantly. And this is the flow chart which we can tell once we have diagnosed, we start a LT4 therapy, hypothyroidism, we start LT4 therapy. Then, if the persistent symptoms, we look for FT3 FT4 ratio. And if it is on the lower side, then we consider DA2 polymorphism, and we consider the trial of liothyronine. And so this is, as I mentioned, LT4 therapy alone will be sufficient for hypothyroidism alone. Along with the DA2 polymorphism, we need to add combination therapy. So most cases are due to adherence or absorption issues. Systematic evaluation prevents unnecessary dose escalation, and the flowchart approach, as I mentioned earlier, would be helpful for us to reach the diagnosis.
Thank you, Shriyam. I think it has been very informative. Now, can you tell us what is RTH alpha then? What is the difference, theoretical difference between RTH beta and alpha for audience sake?
Yes, sir. RTH beta is central resistance, where the patient, affected individual will have thyrotoxic features, because alpha is the peripherally acting receptor, where it acts on the heart, bone, muscles, everywhere. And patient will be having tachycardia, weight can be low, weight can be lost, but the TSH will be mildly elevated, because the T3 is not acting there, and like centrally at the TR beta level, resistance will be there. So persistent TSH elevation will be there, and they will be responding to usually supraphysiological dose of T3, or the absolute treatment would be TRIAC, that is triiodothyroacetic acid. Supraphysiological T3 requirement would be actually 250 microgram alternate day, or 100 microgram daily requirement, very high dose requirement will be there. Coming to RTH alpha is they will have all the TSH, T3, TSH will be normal or mildly, usually normal, because RTH means TR beta will be functioning well only. T3, T4 will be slightly on the higher side, because peripheral action won't be happening, and patient will have a full-blown hypothyroidism features, because all the peripheral actions are mediated by alpha. And there are few cases of both generalized resistance, alpha plus beta.
So basically, if you talk of RTH beta, it is at the pituitary level, and if you talk of alpha, it is extra pituitary or generalized way, and they may be global also. Both may be together. Then second question is, you made a diagnosis of DIO2 deficiency or polymorphism. How common is this mutation in the general population?
Sir, DA2 polymorphism, among the three differential diagnoses, DA2 polymorphism has highest prevalence actually, because in the general population it is about 8 to 12%. However, in certain the white population, it is up to 20 to 30% also. So it is quite common.
So I was going through literature. There's an Iranian study which says that they did this polymorphism, DIO2 polymorphism in patients and hypothyroid patient, and they said that in those patients in whom there is some polymorphism, they required higher dose of T4. And are there any other case reports of DIO2 polymorphism with the hypothyroidism picture or refractory hypothyroidism picture in literature?
There are very few reports which I also I also searched a lot, sir, but only a few, that Iranian study and and one more report where autoimmune hypothyroidism plus D8 polymorphism was noted. And in one of the case reports, anti-TP was negative. In the other report, anti-TP was positive. And they required very high, means higher dose of LT4, and they also responded well to T3 therapy.
Yes. Yes. So, from audience side, are there any questions or any comments?
I think we don't have any questions. Dr. Anish, if you would like to put in some remarks from your end. Yeah.
Yeah. Basically, I think Dr. Sriram has presented a very nice case. The learning points here is that how do you approach patients who come to us with refractory hypothyroidism, which is pretty common. What he said is right. In practice, we see lots of patients with increased TSH in spite of giving doses which are definitely more than 1.9 microgram. And as far as these rare conditions are concerned, probably I think if we work up, some of these patients may have at least DI2 polymorphism, which is like quite common, as Dr. Sriram rightly said. So I think it was overall a very interesting case, two interesting cases. Thanks, Dr. Sriram.
Dr. Pramila, any comment?
I think we had a nice discussion. I was just trying to see if there are any comments or any questions. I think they were difficult cases, so people have not asked many questions also. Very
Okay.
nicely presented, actually. Yeah.
Thank you. So we can move ahead with the second part of the program.
Yeah, sure.
Thank you, Dr. Sriram, for the fantastic case presentation highlighting the various causes and management of refractory hypothyroidism. So I thank the moderators, Dr. Sushil Tindal sir and Dr. Anish Bail sir, for leading an excellent discussion also, and Dr. Pramila Kalra madam for the inputs as well. So, and our next speaker for the session is Dr. Divya Dahiya madam, who will be speaking on dynamic risk stratification of DTC. So can we have madam's CV, please? So ma'am is professor of the Department of Surgery at PGIM at Chandigarh. Ma'am's area of interest include endocrine and breast surgery, and ma'am is also the program in charge of MCH of endocrine and breast surgery. And there are more than 155 publications to madam's credit. Over to Dr. Divya ma'am for the insightful presentation.
Good morning, everyone.
Ma'am, we are able to hear you, ma'am. You're muted again, ma'am. Tech team, can you help madam with the presentation?
Yeah, sure, ma'am. I'll just connect with her and check.
Sure.
Hello. Can you see my slide share? I'm not able to see it on your screen.
We are seeing your slide. Yes, it's moving also.
I do.
It's in the full screen mode only, ma'am.
Can you see?
Yes, ma'am.
Okay. Good evening, everyone. Nice to be here with you again. See, I will be speaking upon dynamic risk stratification in the differentiated thyroid cancer. As we all know, clinical behavior of differentiated thyroid cancer, it varies between indolent, slowly progressing tumor to a highly aggressive tumor. And it is important to avoid overtreatment for low-risk cancers. And according to 2025 ATA guidelines, they have stressed upon that after diagnosis, we should assess the risk benefit, whether this patient need active surveillance or active treatment in the form of surgery. And after treatment, they have again advised to reassess the risk and decide for the further management and follow-up of these patients. And risk assessment has been divided as low risk, low to intermediate, intermediate to high risk and high risk patients, which is based on the histological nature of the tumor, presence of the cervical lymph nodes, AJCC staging, and postoperative serum TG and TG antibody levels. Molecular profiling of the histological specimen postoperatively is not recommended routinely, except in few cases or if it is being performed otherwise for some academic purpose. So the 2025 ATA risk stratification system predicts clinical outcome for patients of differentiated thyroid cancer after the initial diagnosis, and this assessment should always be done within 3 months of the surgery so that we can categorize them ranging from low to high risk. And what is the key difference from 2015 to 2025 guidelines? In 2025, they have included that microscopic extrathyroid extension is no longer required to upstage a tumor. Similarly, any vascular invasion is significant. We should not wait that when the more than 4 vessels are involved on the pathological specimen. Similarly, they have given importance to the lymph node number, size, and presence of the extranodal extension, and molecular and features, as I suggested, it is not the routine part, but whenever they are available or in high-risk patients, it should be performed regularly. So after the response, after the patient takes treatment, again the risk stratification is done based on the response to the treatment. And how do we do? By doing the neck imaging and stimulated or non-stimulated TG, anti-TG levels. If the TG levels are less than 0.2 after total thyroidectomy, with or without neck dissection and radioactive ablation, the response is considered as excellent. If it is indeterminate when the TG levels are between 0.2 to 1 without any structural disease on the neck ultrasound. And it is biochemically incomplete when the TG levels are high, but there is no structural evidence of the disease in the neck on the high resolution neck ultrasound. And it is structurally incomplete when we have a gross evidence of disease in the neck after surgery. So based on the response of excellent to structurally incomplete, TSH suppression is advised. So in the ATA 2025 guidelines, they have said after the diagnosis, when we do the surgery, risk stratification, it should be done within 3 months of the surgery. And based on that, we decide for the further treatment that should be performed within 6 to 12 weeks after surgery. And further aim for the TSH suppression based on whether the patient falls into the excellent response or the poor response. And role of radioactive iodine after thyroidectomy is now no longer recommended in each and every patient. If the patient is in the low risk category, in those patients, there is no need for radioactive iodine ablation or uptake scan as well. In patients who falls into the intermediate low or intermediate high group, radio iodine uptake scan can be considered, but whether to ablate or not, we have to keep in mind all the parameters which I have just mentioned. And however, the patients who have risk category of high or already have known distant metastasis, in those patients, uptake scan followed by ablation is recommended routinely. So once after surgery, we do risk stratification, decide for the radioactive iodine uptake scans after 6 to 12 weeks. Further assessment will be done again after 6 to 12 months. So it's an ongoing process, and at every stage, reassessment is performed to see whether this patient needs further aggressive management, or we can decrease the frequency of the management as well as the type of investigation which we order for each and every patient. So it is a continuous reassessment of post-treatment response, which represents a paradigm shift from every patient cannot have the same line of treatment, and it integrates initial clinicopathological risk with the patient's response to the therapy. And aim is so that we can avoid over-treatment and intensive follow-up in the patients who have a good prognostic factors, and focus the therapeutic efforts on the patients who have worse prognosis and who requires more aggressive management. And it provides real-time risk assessment at any points, because we will be following our patients regularly every 6 to 12 months, depending on the initial risk stratification and the response to the therapy, what we have given, like only thyroidectomy or thyroidectomy with the radioactive ablations. So, as I mentioned, we divide it into excellent, biochemically incomplete, indeterminate, and structural incomplete response. So, if we see the after risk stratification, this is the response. Even in the excellent response, the risk of recurrence is to the tune of 3 to 15%. So we have to see all the features to decide whether the patient is in the low or in the high risk of recurrence. So based on that, we can decide the follow-up. So in this group, patient needs more aggressive follow-up, but if the patient is having excellent response and low risk stratification features, they need not to be followed up very aggressively. And as the treatment response decreases, the risk of recurrence proportionately increases. And how to follow up these patients? The two main investigation is the high resolution neck ultrasound and the serum TG, anti-TG levels. And how long to continue? I will come on that subsequently, but the TSH suppression goal is recommended that in low and intermediate risk patients, we need not to suppress TSH level significantly. To the aggressive suppression is not required, only moderate suppression or TSH level normal to less than 2 is okay, because it avoids development of the subclinical thyrotoxicosis. As there are various studies where it has been shown that if the TSH level is less than 0.1 milliunit per liter, it does not change the progression-free, disease-free, and relapse-free survival if we keep it even below that. And in the patients who have undergone total thyroidectomy with or without radioactive iodine ablation, falls into the excellent response. The TSH suppression is significant. High-grade TSH suppression is not required, and we can stop follow-up of these patients by neck ultrasound after 5 to 8 years, and we can continue to follow up these patients with TG, anti-TG levels only. And the patients who underwent lobectomy only, these patients need ultrasound neck every 1 to 3 years based on their risk stratification for 5 to 8 years. And then we can stop surveillance of these patients. And so if the patient is doing well after surgery, radioactive ablation, and the TSH suppression, we can follow up them with 6 to 12 months for 5 to 8 years, and we can stop surveillance if they are performing well. However, if any patient there is change in the TG levels or we find structural disease, then the surveillance should be continued aggressively. And there is no definitive role of radiotherapy in these patients of differentiated thyroid cancer until or unless there is extrathyroidal spread which is not resectable. So the dynamic risk stratification is a continuous process, start with the after surgery when we consider the histopathological features and we decide to treat with the radioactive iodine or only TSH suppression, and then reassessment every 6 months. And after 2 years, we can change the follow-up policy if the patient is still under low risk. So ATA 2025 guidelines, it retains the principles. However, it has refined the criteria. So the take-home message will be dynamic risk stratification is an ongoing individualized evidence-based post-treatment response to treatment throughout the journey of thyroid cancer treatment. And it revises recurrence risk at every 6 to 24 months and thereafter, and we can stop follow-up in some of our patients. Thank you.
Thank you, Dr. Divya Madam, for a very comprehensive presentation highlighting the changes of the ATA 2025 DTC guidelines. I request the tech team to display the QR codes related to thyroid research in practice.
Sure, ma'am. And can you please stop sharing your screen? Thank you.
So a very short announcement before we proceed with the quiz. So those who are interested to submit their research to the flagship journal, that is Thyroid Research in Practice, can do so by scanning the QR code which our tech team is going to display. And those who are interested to become a reviewer for the Thyroid Research in Practice, again, can do so by scanning the QR code displayed here. This will help you sign up as a reviewer as well. So, and now moving on to one of the most awaited segments of the thyroid clinics, that is the ITS thyroid clinics. So our quiz master for the evening is Dr. Parag Agarwal, who is the assistant professor in the Department of Endocrinology, LTMMC, Sion, Mumbai. So we will have a brief quiz brief instruction on the quiz rule. So it is important that to click on the button attend quiz for you to live stream the screen. The quiz will be conducted via the Slido platform. Each quiz question will be displayed with a 30-second time limit for the responses, and the quiz has about a total of 10 questions. So I request Dr. Parag Agarwal to start the quiz.
Yes, thank you so much, ma'am, for that kind introduction.
Yeah, sir, I will give you the cue, sir. I will give you the cue when to screen share, sir.
Sure.
Then you can start, yeah. Share the screen, sir, not the questions. Let the audience join first, sir.
Okay, okay.
Meanwhile, I'll give a brief introduction about Dr. Parag Agarwal. So Dr. Parag Agarwal is assistant professor at the LTMMC Sion Hospital in the Department of Endocrinology in Mumbai. So Dr. Parag Agarwal has won a gold medal in the DM exit exams and has numerous publications, both national and international journals to his credit. Along with that, he's also awarded the best reviewer for one of the journals at RSSDI Kochi, that is the International Journal of uh, yeah, that is IJDDC, that is the International Journal of Diabetes in Developing Countries. And he's also the one of the reviewer for Fluent Health Digital Health Company, and has delivered more than 15 lectures, talks, and webinars as well. So over to Dr. Parag.
Thank you. Thank you so much, ma'am, for that kind introduction. Thank you, Indian Thyroid Society, Pramila Kalra ma'am, Bhaskar sir, for this opportunity. And it's glad being back on this platform. Tech team, may I please share my slide?
Yes, sir, you can share the slide, sir.
Yeah.
But I'll tell you when to ask the questions.
Yeah. Sure. So, are my slides visible, and am I
Yeah, you can
audible
go
clearly?
to slide mode, sir.
Yeah.
Just wait for a minute more, sir. I'll let you know.
Sure, sure.
I think you can start, sir, now.
Okay. So this is a set of 10 questions for the DM residents. The questions are really simple, and many of them have already been discussed in our classes today. The first question is, which of the following is incorrect regarding thyroxine metabolism in the body? Option A, thyroxine is primarily excreted by the kidney, while approximately 20% of T4 is excreted in the stool. Option B, thyroxine is predominantly absorbed in the small intestine, more specifically through the duodenum, jejunum, and ileum. Option C, urinary excretion of thyroxine increases with age. And option D, around 60 to 80% of the ingested thyroxine dose is absorbed within the first 3 to 4 hours of ingestion.
I will let you know when to move on to the next question, sir.
Sure, sure. Incorrect regarding thyroxine metabolism.
The next question, sir.
Question number 2. Which of the following is a correct pair of thyroid hormone receptor subtypes and their location in the human body? Option A, TR beta 2 in liver kidney. Option B, TR beta 1 in thyroid and brain. Option C, TR beta 1 in heart and bone. And option D, TR beta 1 in the retina and cochlea. The correct pair. This was also discussed in a case presentation today.
The next question, sir.
So question number 3, pick the incorrect statement regarding COVID-19 and thyroid involvement. The virus enters through the angiotensin converting enzyme type 2 receptor. Option B, possible mechanisms include molecular mimicry and activation of B lymphocytes. Option C, ultrasound thyroid typically shows an increased vascularity. Option D, no difference in the outcome of illness between mRNA and inactivated or vector vaccines.
The next question, sir.
Question number 4. Which of the following cases should be treated with LT4 replacement? For reference, the normative range of TSH is 0.4 to 4.2. Option A, 82-year male with TSH 7.2 and normal TT4, that is total T4. Option B, 25-year asymptomatic female with TSH of 6.1. Option C, 32-year female with primary infertility and TSH of 5.4. And option number D, 40-year-old lady asymptomatic with TSH2 and TPO antibody 500 international unit per ml, the normal range being less than 34.
The next question, sir.
Question 5. Which of the following is not a differential diagnosis of refractory hypothyroidism? This was also discussed today. Option A, hypercortisolemia. Option B, hypoalbuminemia. Option C, obesity. And option D, sick euthyroid syndrome. Not a differential diagnosis.
So next question, sir.
Question 6, again from our class today. The incremental value above what level at what hour may be useful to rule out the malabsorption workup as per the protocol for levothyroxine absorption test. This is about the levothyroxine absorption test, at what hour we are checking for the level and at what incremental level we count it to be significant. These are your options.
The next question, sir.
Question 7. Which of the following is incorrect regarding the carcinoma of the thyroglossal duct cyst? Option A, most common papillary carcinoma on histopathology. Option B, usually presents at the age of less than 20 years. Option C, women are more commonly affected than men. And option D, prognosis is good.
The next question, sir.
Question number 8. Which of the following subtype is not classified as an aggressive histology of differentiated thyroid cancer? Option A, follicular variant. Option B, tall cell variant. Option C, columnar cell variant. And option D, Hobnail variant.
The next question, sir.
Question 9. Choose the incorrect statement regarding radio frequency ablation for thyroid nodules. Option A. Thyroid nodules should be confirmed as benign on at least 2 ultrasound guided FNA or CNB, that is core needle biopsy, before radiofrequency ablation. Option B, a single benign diagnosis on FNA or CNB is sufficient when the nodule has ultrasound features highly specific for benignity. Option C, a single benign diagnosis on FNA or CNB is sufficient for confirmation of a benign nodule identified as a functioning thyroid nodule and autonomously functioning thyroid nodule. And option D, radiofrequency ablation is not indicated for a toxic nodule.
The next question, sir.
Option 10, identify the gene mutated in Pendred syndrome. These are your 4 options.
Thank you so much, sir.
Thank you.
Thank you, Dr. Parag, for the very engaging session. So I now request you to share the answers for the DM quiz while our tech team collates the result.
Okay, ma'am. I hope my slides are visible, ma'am.
Yes, Dr. Parag, it's visible.
Yeah. So regarding this first question about the thyroxine metabolism in the body, so it's option C, because we should know urinary excretion of thyroxine decreases with age. The other options are correct. This has been taken from our flagship thyroid research and practice journal, and respected Jindal sir is the moderator for today's session. It is from his paper. Second question, this was again discussed about the thyroid hormone receptor subtypes and their location in the body. Option B, TR beta 1 is present in thyroid and brain. And these are the multiple subtypes. TR alpha 1 in the heart, brain, muscle, skeletal muscle, bone and GIT. TR alpha 2 and TR alpha 3 lack T3 binding activity. TR beta 1 is mainly present in the liver, kidney, brain, and thyroid. TR beta 2 are present in the hypothalamus, pituitary, cochlea, and retina. TR beta 3 is present in the liver, kidney, and lung. And TR beta 4, a relatively newer entity, it lacks the ligand binding domain. Option 3 about COVID-19 and thyroid involvement. So obviously, because it is a thyroiditis type of picture, ultrasound won't show an increased vascularity. Increased vascularity goes more in favor of Graves' disease. The other presentation is normal. The typical ultrasound characteristics of subacute thyroiditis, that is enlarged gland, heterogeneous ecotexture, and patchy hypoechogenic areas with decreased vascularity are observed in these cases. Again, taken from a thyroid research and practice journal. Now, management about subclinical hypothyroidism or those with an increased age. So the patient who should be treated is a young female with infertility and a slightly raised TSH. These are the indications as laid out by the consensus statement from the Indian Thyroid Society, where they say any patient with subclinical hypothyroidism, age less than 65 years, TPO antibody negative, may not warrant a treatment if the TSH is less than 10. But any patient with TSH more than 10 should be treated provided the patient's cardiac status is fit. And for patients beyond 65 years, a liberal target of TSH may be advised. Question 5, which of the following is not a DD of refractory hypothyroidism? It's hypercortisolemia, because the correct answer would have been hypocortisolemia, as we can see at the bottom of the table. These are the multiple approaches that they have given for diagnosing refractory hypothyroidism and what could be the cause for the same. About the levothyroxine absorption test, as was alluded to by Dr. Sriram, it is 0.4 nanogram per deciliter or 50% increment at the time of 3 hours. And they have given a sensitivity of 97% and a specificity of 80% for this test, as advised by Dr. Sujay Ghosh sir for the levothyroxine absorption test. Regarding the carcinoma of the thyroglossal duct cyst, the incorrect options out of these was age at less than 20 years. It should have been between the age of 20 to 50 years of age. Again, taken from a flagship thyroid research and practice journal. Not an aggressive histology of differentiated thyroid carcinoma. It is the follicular variant. It is considered to be a better variant out of all these. The tall cell, Hobnail variant and the columnar cell variant are all considered to be aggressive histology, and they classify for the intermediate risk, as madam was alluding to in a lecture. Regarding the indication for radiofrequency ablation for thyroid nodules, it is obvious that it should be documented as benign, and it is not true that it is not used for toxic nodule. It can also be used for toxic nodule, provided that we have ruled out any malignancy in the nodule. These are the indications as given from the 2017 guidelines. And regarding the gene mutated in Pendred syndrome, it is SLC26A4. SLC26A4, the last option. Thank you so much.
Dr. Parag, you can also share the answers for the MD quiz as well.
Sure, ma'am. So these were the questions for the practitioners quiz or the MD students that were shared earlier. The answers would be discussed today. Pick the incorrect statement regarding ectopic thyroid. So the incorrect option would have been option C. The thyroid gland develops from the median ectodermal thickening of the floor of the hypopharynx. It develops from the endodermal thickening of the floor of the hypopharynx, and then it descends towards its natural side. The other options are correct. It is the most common location is lingual thyroid. Multiple transcription factors may be associated, and immaturity with low functionality of the thyroid tissue is common in ectopic thyroid tissue. Question 2, regarding the iodine metabolism, which of the following is incorrect? The incorrect statement is it is not absorbed from the ileum in the humans. In fact, it is absorbed from the stomach, duodenum and jejunum in humans, and not from the ileum. The other options are correct. Question 3, which of the following is not a differential diagnosis for subclinical hypothyroidism? It is the peripheral tissue resistance to thyroid hormone, which is not a DD. Other options are correct. It is amiodarone use or untreated adrenal insufficiency or recovery phase of the euthyroid 6 syndrome are all the DDs for subclinical hypothyroidism. This is a brief list which has been provided from the Indian Thyroid Society of subclinical hypothyroidism. Question 4, which of the following is not a physiological change in thyroid function in pregnancy? Now we need to know that pregnancy, the thyroid status and the iodine status behaves differently, because here the mother has to take care of herself as well as the child, and hence she also has to take care of the thyroxine of the baby who is not able to produce it on his own. So there are the certain changes, and here option C was the incorrect statement, that TBG levels fall back to the pre-pregnancy level after mid-pregnancy, when in fact it peaks at mid-gestation and is maintained throughout after that, the TBG levels. Question 5, according to the ATA guidelines, which of the following cases of hypothyroidism in pregnancy should be treated with LT4? So it was 30 weeks gestation with TSH of 11.2 and negative anti-TPO that should be treated. These are the guidelines that have been given by the ATA, and when to treat and when to consider treatment is also given here. Regarding the use of anti-thyroid drugs in pregnancy, we often tend to think that propylthiouracil is a good drug, or maybe methimazole, carbimazole is not a good drug, but then even propylthiouracil tends to have its set of potential adverse effects. and one of them is cystic malformation of the face. Because exposure to PTU in the utero has been associated with less severe birth effects, such as cystic malformations of the face or neck, hydronephrosis, or cyst in the urinary tract. It is only a give and take between PTU and methimazole because PTU has a lesser severe birth defect. Hence, we tend to use this in the first trimester of the pregnancy. It is not that it is completely safe. Regarding the thyroid scoring on ultrasound for thyroid nodules, which of the following adds the highest points is extrathyroidal extension. So the highest points are given to very hypoechoic status, extrathyroidal extension, and taller than wide shape on ultrasound. This has been taken from the thyroid research and practice and the consensus statement of the ITS. Now, which of the following is not true regarding the use of radioactive iodine for Graves' disease? So it is obviously not safe in thyroid-associated ophthalmopathy. In fact, it can precipitate the condition in patients with uncontrolled Graves' disease. And these are the definitive indications about the management of the same. Which of the following is not a primary indication for imaging in suspected or confirmed thyroid eye disease? Now, not all cases of thyroid eye disease require imaging. It is only indicated in certain conditions and not at all required in upper eyelid retraction. It is indicated for exclusion of other diagnosis in atypical cases like in hypothyroid or euthyroid cases, in clinically unilateral disease or markedly asymmetric disease, absent upper eyelid retraction, upper lid ptosis, atypical strabismus, severe orbital pain, or for sight-threatening TED, or as a pre-op management of the case. These are the only indications for imaging in these cases. And the last question, incorrect statement regarding tau, that is thyroid-associated orbitopathy, that it is always diagnosed after diagnosis of Graves' disease. In fact, it can be diagnosed before, concurrent with, or after the Graves' disease. Thank you so much.
Team, do we have the winners for the quiz?
Yes, ma'am. I'm just going to display.
Thank you, Dr. Parag, for a very captivating quiz and for discussing the answers also very elaborately.
Thank you, ma'am.
So the tech team is going to display the winners. So you may do the honors of announcing the quiz winners.
So the winners of the quiz, number 1, Dr. Sneha. Number 2, Dr. K. Can you please identify yourself so that we can send the certificates? And rank 3, Dr. Annie. Hearty congratulations to all of you.
The winners can please send their names, especially Dr. K, so that we can send the certificate.
So the winners of today's quiz, so these are the winners of the today's quiz or the DM quiz, sorry, the practitioners quiz tech team?
Ma'am, these are the winners of today's quiz.
Okay. So the practitioners quiz, can you display the winners as well? So the winners, yeah, Dr. Parag.
Ma'am, please, ma'am.
Please, yeah. So the winners of the practitioners quiz include Muhammad Gauss, Srishti Singh, and Lavanya Murugan. So congratulations to all the quiz winners. So moving on, so as we conclude today's session, I'd like to invite Dr. Pramila Kalra, Madam, to give the closing remarks. Over to Madam.
Yeah, thank you, Dr. Ganvi. I think we had an excellent discussion on refractory cases of hypothyroidism, and then followed by the talk by Dr. Divya on the dynamic risk stratification in differentiated thyroid cancers, and then an excellent quiz by Dr. Parag. I think Dr. Parag will be happy to join us later also in other future quiz sessions as well.
Definitely.
So we had a nice quiz session with Dr. Parag for students, and the general practitioners quiz also winners. We congratulate them. And I again thank Dr. Sushil Jindal and Dr. Anish Behel for being the moderators today, and Dr. Sriram for the presentation. And I think the case discussion and everything was excellent as usual. And we hope to meet again in future with more thyroid clinic sessions. And also I request everyone that if you have any article which is on thyroid, please submit to our flagship journal of Indian Thyroid Society, which is the Thyroid Research and Practice. And also the faculty are welcome to become reviewers of Thyroid Research and Practice, because we need more and more reviewers. So if any one of you are interested, please message me or Dr. Ganvi. So we'll be happy to put you as reviewer for the journal as well, because we need more reviewers to review our articles as well, because that's the journal of the Indian Thyroid Society. So we want it to grow further. And this is the code through which you can become a reviewer. And we also have a code before that where you can go to the Thyroid Research and Practice website and you can submit your articles. So with that, I hand it back to Dr. Ganvi to finish the proceedings for today, and also to announce for the next month Thyroid Society webinar as well, and also our next clinics, because we'll be having a special clinics in January because it's a thyroid awareness month. So we are having a special session that time.
Thank you, ma'am. A heartfelt thanks to our moderators, Dr. Sushil Jindal sir and Dr. Anish Bail sir, for an excellent discussion, and Dr. Sriram for presenting very interesting cases on refractory hypothyroidism, and also our speaker, Dr. Divya Dahiya madam, for guiding us through the management of DTC as per the 2025 consensus. And our quiz master, Dr. Parag Agarwal, for making the quiz definitely engaging as well. So our next thyroid clinic session is scheduled for the 12th of January on account of the Thyroid Awareness Month, and we shall have very short monologues for about 10 minutes duration. So this will be followed by panel discussion in the field of endocrinology and also endocrine surgery with national as well as international faculties. So we request everyone to join us for the same. Thank you one and all for joining, and we look forward to seeing you the next time. So with that, we conclude. Thank you.
Thank you.
Thank you. Good night, everyone.
Good night, ma'am. Good night, Dr. Parag.
Good night.